Welcome to this short video on renal and aortic ultrasound. Let's first start out with renal ultrasound. And like any abdominal ultrasound imaging, you'll want to have good technique. The first thing is just to be comfortable. So you don't want to be like this guy right here who's crouched over, probably a little nervous for obvious reasons, but he's really just straining his back this way. So this is the wrong way to do it. You want to, in general, be at about the level of your patient. So you can sit down or raise the bed up to about the level of your hips. Next, this is towards the head and this is towards the feet right here. Notice that the kidney isn't actually parallel with the bed, but actually there is a little bit of a rotation downwards this way. So in order to stretch out the kidney, you actually want to point the indicator towards the bed a little bit. This also is really helpful when you use a curvilinear or C60 probe, in that when you stretch this way, your ultrasound cross-section becomes more parallel with the intercostal space. So you actually reduce your rib shadowing by just pointing posteriorly with the curvilinear probe. This is what a kidney looks like in short axis. Now, when you rotate the probe indicator towards the bed a little bit more, you'll see that the kidney starts to stretch out. And really what you're doing is that you're taking an image of the long axis of the kidney just by rotating that probe. Next, you want to have appropriate gain. See how here you don't really see the renal cortex or the pyramids very well? You see the sinus, that's good. But you really want to have a gain where you can see both sinus, cortex, and these hypoechoic wedges, which are the renal pyramids. Once you have appropriate gain and depth, you'll want to fan through the entire long axis of the kidney. Remember, with ultrasound, you only get a two-dimensional cross-section of a structure, so that's why it's important to fan through the entire structure. Once you do this, you want to rotate the indicator 90 degrees to obtain a short axis of the kidney, usually with the indicator pointed to the ceiling. So there's definitely multiple compartments in the retroperitoneum around the kidney. There's the anterior pararenal space and the posterior pararenal, and then there are the perirenal spaces here. A lot of this doesn't translate very well on ultrasound. What we are really interested in point of care ultrasound is just the kidney itself. And here you could see the renal sinus with the calyces, you have the blood vessels going in, the ureter itself. You also have the pyramids right here, and then the cortex is surrounding the pyramids, and the capsule is around here as well. On ultrasound, most of the sinus and the calyces will appear rather hyperechoic, labeled 4 right here. And then the pyramids themselves will look like hypoechoic or anechoic wedges on top, and the cortex will look like liver density almost. And then on top of this is actually the paranephric or pararenal fat, which is hyperechoic. It looks very much like a chocolate muffin with marshmallow inside, with the cortex being right here and then the sinus being bright white, with little black swirls of representing the calyces. This is a long axis view of the kidney. We're fanning through the structure. And then this is a short axis on the right here, where we're fanning through as well. And notice that we actually have to go in between ribs to avoid shadowing. So our main indication for point of care renal ultrasound is to assess for hydronephrosis. This is probably the most common false positive, a cyst. You can see there's a cyst on the inferior pole of the kidney, a rather large one actually. And then this is a short axis view of the same cyst. I want to take a few moments just to talk about cysts and the classifications. There's something called the Bosniak classification, where it talks about the type of cyst and their potential for malignancy. And in terms of point of care ultrasound, there's no good literature in terms of our ability to differentiate these different types of cysts. However, if you do see a cyst, definitely get a short and long axis view of them. If you have really good imaging, you can oftentimes determine if they're simple. So simple cysts will be round, it not have irregular borders. It will be less than 3 centimeters in diameter, And the wall of the cyst will be very, very thin or even imperceptible. It should not be thick or calcified. And inside the cyst, you shouldn't see anything at all. So there shouldn't be any internal echoes. Then there should be posterior acoustic enhancement, which is typical of any fluid-filled structure. So in general, it's a good idea to get a formal ultrasound if you do see a cyst. Oftentimes it's because we aren't able to visualize it properly. But if you are confident that you have good images, and especially if your institution has good follow-up, you may be able to document your findings on the record and refer the patient appropriately for follow-up. This is another false positive of hydronephrosis, where you actually have prominent pyramids. Pyramids are hypoechoic wedge-shaped structures right here that are pretty uniformly spaced in the periphery and not involving the renal sinus below right here, which is still bright white. This is a fetal kidney right here where you can see very prominent pyramids. How do you classify hydronephrosis? Well, note that it always starts in the renal pelvis. So if you have something that is obstructing the ureter, you're going to have a backflow right here, and it's going to dilate in the renal pelvis first. Then you actually have calyceal dilatation, and then you progress to blunting of the papillae right here. So note that they're crescent shaped right here or downward, and now they're upward facing. Then when you have cortical effacement, you have grade 4 hydronephrosis. There are actually several different societies that have their own classifications, but in general, there's a mild, moderate, and moderate severe, and then severe right here. Another way to think about this is to flip this over and think about a tree. So a tree has a tree trunk. So if you only see the tree trunk that's black or hypo or anechoic right here, you're looking at obstruction up to the level of the renal pelvis, and so this is mild hydro. If you start to see calyceal dilatation, which represents the tree branches, then you'll have moderate hydronephrosis. And then if you see blunting of the papillae, then you have moderate severe. Oftentimes it's hard to differentiate these two, so typically you just want to say moderate to severe if you see any of these. And then if you actually see cortical effacement or the foliage or leaves on the tree, you have severe hydronephrosis. This is mild hydronephrosis, where you only see the renal pelvis that is dilated with anechoic fluid right here, but the calyces are not involved, and neither is the cortex. This is moderate hydronephrosis, so you start to see the branches of the tree or the calyces being dilated from the hydronephrosis. So this is moderate. Again, you can't really tell oftentimes whether the papillae are blunted or not. So typically I would just call that moderate to moderate severe. And then this is severe hydronephrosis, where you actually have blunting or effacement of the cortex. I get this question a lot. How long can someone have hydronephrosis before they have irreversible kidney damage? And usually it only happens with the moderate to severe or severe hydronephrosis, where there's cortical effacement. And it will actually take 2 to 4 weeks before you have irreversible renal damage. So in the vast majority of cases, hydronephrosis is reversible if the onset is within 1 to 2 weeks. This is a stone in the renal parenchyma right here. You can see that there's some shadowing right here and a hyperechoic cortex of the stone. This is a stone in a uretopelvic junction right here, the UPJ stone, where it's actually just in the renal pelvis and it's obstructing there. And then this is the same stone in the short axis of the kidney. Again, you can see it right there. This is a ureterovesicular stone, where it's just about ready to enter into the bladder, and you can see that it's hyperechoic borders with the shadowing and a very, very dilated ureter on the right side. This is a bladder stone, very, very hyperechoic cortex right here with shadowing, and this is the same stone on a sagittal view of the bladder. There are a couple of caveats to assessing for hydronephrosis. The first is that if you actually have a dehydrated patient who's been vomiting, the obstruction may be minimal compared to someone who is adequately hydrated. So If you have someone who clinically looks dehydrated, then you may decide to give some IV fluids and then reassess the hydronephrosis. On the flip side, if you have someone who has been drinking a lot of fluids, they may have a mild degree of hydronephrosis without actual obstruction. So if you have no symptoms for obstruction, like flank pain, nausea, vomiting, etc., then it's less likely to be a true positive. How good are emergency physicians in diagnosing hydronephrosis on ultrasound? Well, there have been several studies that look at this. We'll talk about the Stone study in just a little bit, but essentially, the sensitivity and specificities are in the high 80s up to the 90s, and they've used the hydronephrosis on CT as the gold standard. What's important also is that this comes at very minimal training. So most of these emergency physicians have had just 1 to 5 hours of training to evaluate for hydronephrosis, and they're pretty good at it after that. In the cases where they have had false negatives, it's been with mild hydronephrosis, which one can argue has very little clinical significance. And in terms of false positives, they usually identify renal cysts or prominent renal pyramid and call that incorrectly as hydronephrosis. This is the Stone study that I mentioned. It was a randomized clinical trial of involving 17 emergency departments in the U.S., where suspected renal colic patients were randomized to 3 arms, one getting a CT-KOB, another group received a renal ultrasound by the radiology department, and the last group received an ultrasound performed by the emergency physician. Each group had roughly 800 to 900 patients, and primary outcomes in terms of accuracy, misdiagnosis, pain level, and return visits at 6 months did not differ amongst the groups. So it's very unlikely that we have another study of this size and caliber. So if you want to know how good you can be in terms of diagnosing hydronephrosis at the bedside, this is the study to read. So what other pathologies are out there? Well, you can have a Staghorn calculus. The key is that this is all very, very dense and hyperechoic with shadowing in the renal sinus. You can also have polycystic kidney disease, and you'll see multiple cysts. This image actually has a very atrophic kidney. Most kidneys are about 10 centimeters in length by 4 centimeters wide. And you can see that this kidney is much smaller based on these rough measurements on the side. Next, you have a perinephric abscess. You'll note that the kidney actually is right here, and near the inferior pole of the kidney, you have this complex cystic structure that is a perinephric abscess. So most of it is actually outside of the kidney. Next, you have nephrocalcinosis. This is medullary nephrocalcinosis, where you have very, very bright hyperechoic renal pyramids. Remember that they usually are hypoechoic or anechoic wedge-shaped structures. Here, they're very bright white, and they even shadow right here. And then last is renal cell carcinoma. You note that the renal pelvis is distorted. The calyx is actually a little bit dilated, but there's echogenic material here. And then the renal pyramids are all distorted as well. Look at this one. It looks like it's almost a Mickey Mouse ear right here. Now, no one expects the point of care user to be able to diagnose these pathologies, but in general, if you see something that looks abnormal, it's a good idea to get the formal ultrasound. And for most of these, with the exception of probably perinephric abscesses, you don't need to get an emergent ultrasound. You just need to ensure that they have a follow-up formal ultrasound. Switch gears a little bit. So neither of these pathologies are the most dangerous differential for flank pain and renal colic. I'll give you guys a hint what is the most dangerous. It can also be detected on ultrasound, and that is abdominal aortic aneurysms. This video is combined because a lot of times, especially with our older patients, even though we think that it's renal colic, we always have to ensure that we're not dealing with a AAA. So how do these two go together? Well, actually, Einstein was diagnosed with a AAA when he was 69 years old, and he had a procedure where they essentially put cellophane around the serosa of his aorta to cause fibrosis and then to reinforce the outer wall of the aorta. Unfortunately, this only lasted for a while as he died from a ruptured AAA 7 years later. So just a brief review on some of the risk factors in men over age 65 with the risk factors like smoking, peripheral vascular disease, a first-degree relative with a AAA. there's more than a 10% prevalence. Now, when the decision is made to operate electively before rupture, there's 5% perioperative mortality, but when it's ruptured, that jumps up to 50%. Keep in mind also that with diagnosis, the classic pulsatile abdominal mass is only present in less than a quarter of the cases. And this is why ACEP, the American College of Emergency Physicians, recommends that we perform AAA ultrasound or aortic ultrasound on patients that present with syncope, hypotension, abdominal pain or mass, flank pain, or back pain, especially with the right risk factors. So your typical aorta will be less than 3 centimeters in diameter, and then when a AAA is greater than 5.5 centimeters in diameter, you could see that the rate or the risk of rupture becomes geometrical. It turns upwards, and so this is why the indication to operate is at about 5.5 to 6 centimeters. Also keep in mind that there's a small subset of patients that have AAAs under 5 centimeters that can rupture. And that's why if someone has a AAA, this is an emergent vascular consult. Other things to consider, especially if you're able to find previous documentation of a AAA, and if there's a significant diameter change, even if it's less than 5.5 centimeters maximum, you want to get an emergent consult. Or if there's a change in the size of the intramural thrombus, which is characteristic of most chronic AAAs, or if there's increasing wall dilatation, especially in a saccular AAA. These are the two main types. You have the saccular aneurysm right here, which is a little sac or little ball coming out of the aorta. And then this is the more characteristic fusiform, where it's a circumferential dilatation of the aorta. This is a fusiform AAA. You have the inner lumen, and then you have the intramural thrombus, and then you have the true diameter outside right here. This is a saccular aneurysm. Note that we actually have to use color Doppler to identify it. So you can see that it bulges out just on the top or the anterior of the aorta. This is relevant anatomy for aortic ultrasound. You have your most proximal bifurcation of your descending aorta, the celiac trunk right here. The bifurcations will be the common hepatic artery going to the patient's right, and then the splenic artery going to the patient's left. About 1 to 2 centimeters inferior to the celiac trunk, you have your superior mesenteric artery takeoff. This is really important that you're able to recognize this on ultrasound, because this is the beginning of the distal aorta up to the bifurcation. And when you are able to recognize the SMA, you can note that just right below, just posterior to the SMA, there's actually a left renal vein that will come between the SMA and the aorta. And this signifies that you're at the level of the kidneys. This is very, very important, again, because most of our AAAs are going to be at the level of the renal arteries or below. And then this is the bifurcation right here into the common iliacs. This is the phase array. This is the curvilinear. I like to use the curvilinear because you have a bigger footprint. You don't have to deal with any rib shadowing, so that's fine. You have more crystals, so there's more resolution. And with the bigger footprint, you have less pressure on the patient because there's a greater surface area that's involved. So for the transverse view, you want to point the indicator dot to the patient's right, like this. And for the sagittal, you want to point towards the head. Remember that between the ultrasound probe and the aorta is essentially bowel with bowel gas, so you really need to compress and displace that bowel. And in order to do that, you need to do gentle compression. I typically, for very obese patients, I put both hands on like this, and I just gradually compress. So whenever they take a breath in and they exhale, I push down a little bit more. And so it's worth spending the time to do this into practice, because there will be cases where you will diagnose a AAA and save that patient's life. And that may be in a 300 to 400 pound patient. So when you first start, you want to go pretty proximal, just a little bit underneath the xiphoid process. You want to identify this liver right here. Identify the vertebral body, which is some people refer to as the spine shadow or the horseshoe sign. And then you identify the IVC, seen in blue, and aorta right here. And this is usually where you want to start off. When you're at this level, you want to maintain your pressure and then slide inferiorly like this. And all of a sudden you'll start to see the celiac trunk, splenic artery to the left, common hepatic artery to the right. And the celiac trunk is commonly referred to as a seagull because it looks like a seagull. And it's nice to be able to visualize the celiac trunk, but in reality, because you have transverse colon and stomach nearby, it can be really hard to visualize this level of the aorta. From the celiac trunk to the SMA, that's considered the proximal aorta. And for the SMA, you have a takeoff, and then it'll curve inferiorly, so that's why you see it in cross-section on a transverse aortic ultrasound. So again, you still have the vertebral body, the spine shadowing. You have your aorta right here. You have your IVC right here. The SMA is highlighted by the yellow arrow. And it looks like that mantle clock. So a mantle clock is a clock that you put on the mantle of a fireplace. Again, this is important to identify this on aortic ultrasound because this tells you you're at the level of the kidneys. And in fact, this vessel right here that courses from the left side to the IVC is a left renal vein. So from here, this signifies the distal aorta. This is where roughly 90 to 95% of your aortic aneurysms are going to take place. So this is where you really need to take note. And so you'll scan all the way down until the bifurcation, which will look like this. So this is the aorta, and then it'll start to bifurcate right here. Right here. So you have the two iliacs. And sometimes we refer to these two as snake eyes looking at you. So in terms of an adequate aortic ultrasound, you want to visualize the aorta in short and long axis. It's nice to be able to get the celiac trunk, but really the critical imaging is that you get a clip optimally from the SMA to the bifurcation. If you're saving still images, you want to save a still image of the aortic at the level of the SMA and at the level of the bifurcation. This implies that you've gone from the SMA to the bifurcation and you didn't see a AAA. You also need to get a long axis at this level in order to have adequate imaging of the aorta. If there is a AAA, then you want to measure the outermost diameter. Here are some tips to doing aortic ultrasound. First, you have to prepare. So if you suspect the person may have a AAA, you want to wheel the machine in, and while you're taking a history, you want to try to perform the AAA evaluation there because you can distract the patients with your interview, and then you can also take your time. Now, if they're in pain, you want to give them some pain medication before you start. But the key is to compress and displace the overlying bowel so that you can visualize the aorta. And in order to do that, you really need to take your time, at least several minutes for most of our obese patients. You can use color Doppler. Again, I'll talk about this. And you can use the low frequency setting for deeper penetration of structures. So this is applying compression. Sometimes you have this bowel gas that just doesn't go anywhere. So what you often have to do is just slide a little bit more lateral and then aim towards the aorta and then push. And then when you push down this way, you push this bowel out of the way. So this is a good example of that where basically you have this bowel gas and then you slide over this way and you're pushing, and then here you see the aorta. The other tip is to use color Doppler when you're not able to visualize the aorta very well. You have the portal vein above, and then this is the IVC with the left renal vein, this is the SMA, and then this is the aorta right here. This is another color Doppler image where you can see the aorta pretty well to the bifurcation. The key is that sometimes if the patient's breathing really fast, you're going to have artifact, or if you're not keeping the probe still, you're going to have some color Doppler artifact. That makes it hard for you to identify the aorta. I don't have an example of changing the frequency settings for aortic ultrasound, but this is a pericardial view. So notice that the right pericardium is nice. The left pericardium could be brighter, so it's hard for you to identify a pericardial effusion here. But take a note of what happens when you push this button. This is on a Sonosite M Turbo, but when you push it to the lowest frequency setting, which is penetration or PEN, you could see that all of a sudden this left pericardium becomes much more visible. And you could do the same thing with someone who is very obese and you can't see anything at all in terms of their aorta. You can lower the frequency setting, and this will reduce the attenuation so that you can see more of the deep structures. So why don't we just do a long axis view of the aorta? Well, it's because of something called cylindrical tangential effect. And what that is that if you image in a long axis, on this schematic right here, you're getting most of the maximum diameter of the aorta. But if you actually are just a little bit to the lateral of that or tangential to that, you may image through this section, and that may give you a falsely small aorta. And that's why if you image in the short axis, you're going to get the entire aorta to get a maximal diameter. Also, for long axis, you may miss the sacral aneurysms. So for instance, if you image right here and the sacral aneurysm is right here, you're going to completely miss that. Whereas if you did a transverse view, you won't miss that. It is important to get the long axis, especially if you're just going to save images, and you want the long axis of the distal aorta, like something like this right here. So if you identify it at AAA, you want to measure the diameter. Sometimes people will make the mistake of missing this intramural thrombus, and they'll just measure this lumen right here, where in fact the true diameter of the aorta is actually from here to here. Same thing on this view right here, where you have an intramural thrombus, and so you don't want to measure here, you want to measure the true diameter over here to here. I cannot emphasize enough how much practice is involved in becoming good at aortic ultrasound. So anytime you have someone with abdominal pain, even though your suspicion is low that they have a symptomatic AAA, just do the aortic ultrasound. The more you do, the better you'll get, and the less you'll stress out about it when you actually have a hypotensive patient who is in front of you with abdominal pain. So let's just say you diagnose a new AAA on ultrasound. You have given the patient the best chance for survival. Why? Well, first you can see if there's actually bleeding in the peritoneum with a right per-quadrant view. And if there is, you can call a stat vascular consult, tell them that there's a ruptured AAA. They can get the OR prepped. You can get the IV lines in place as well as order the blood products. And you've given them at least 30 minutes of advance time compared to doing a CT scan for abdominal pain. CT scans are definitely indicated, especially if they're stable, because they can give the surgical team information that will help them to prepare the best approach for AAA repair. But again, if you've diagnosed a AAA on ultrasound, you've given them the best chance for survival. These are some key references. Thank you again for watching. If you have any questions, please don't hesitate to contact us.